Figlin, the Steven Spielberg Family Chair in Hematology Oncology at Cedars-Sinai Cancer in Los Angeles. And I'm delighted today to be joined for the Kidney Cancer Journal webinar by Arlene Seifert-Radke, who's a professor of genitourinary medical oncology at the University of Texas MD Anderson Cancer Center. And she specializes in effective therapies in the treatment of urothelial cancer and rare tumors. And Dr. Nizar Tanir, a longtime friend of mine, who's a professor in the Department of Genitourinary Medical Oncology at MD Anderson and holds the endowed Ransom Horn Jr. Professorship in Cancer Research and has received many awards, the most recent of which, the John Mendelsohn Lifetime Achievement Award in 2021. So Arlene and Nizar, thank you so much for joining us today.
Thank you, Bob, for the opportunity.
Thank you so much for having us.
So this is a really exciting topic for today, and we'll do this in a very transparent way. So as you know, and I'll address the first question to you, Arlene, we have a long-standing interest in kidney cancer in interleukin-2. And just to put that in perspective, and not to age myself, but in 1990 and 1992, I visited the FDA to review the first and second submissions for interleukin-2, now almost 30 years ago. So, and what we know about interleukin-2 is that it was incredibly difficult to deliver, but incredibly effective for a small subset of patients, producing durable, unmaintained remissions, which we consider to be cures. And it was for that reason that it was approved, and then it's been used moderately by selected physicians over the last several decades. We and others have tried to find biomarkers for activity to predict who would benefit, and we're really unsuccessful in that regard, and are really very excited when we started to learn that there might be a next generation interleukin-2 to start to ask and answer questions about that. So Arlene, the first question is really, how does pegulation affect IL-2's pharmacology? And how does BEMPEG differ in its pharmacologic activities than the more traditional interleukin-2 that we've been using for decades?
So those are great questions, because bempegaldesleukin is not our daddy's IL-2. It's clearly different in its toxicity and clinical activity. IL-2, being a cytokine, really has PKs that aren't durable in the circulation. So when you administer intravenously, we see that it's taken up very quickly. And at the doses that were given back in the day when IL-2 reigned as king for the treatment of renal cell carcinoma, we did see that excessive toxicity, profound hypotension, cytokine type syndromes, diffuse edema, and frequent transfers to the intensive care unit, which resulted in IL-2 being limited to a young, healthier patient population. With the pegulations that are given to IL-2, what happens is that there's 6 pegulations added to IL-2. And as a result of these pegulations, the infusion of IL-2, even though it's given over a short interval, it now remains in the circulation for a longer period of time. In fact, the PK suggests that it remains in the circulation for up to about a week. So what is happening is we're seeing prolonged stimulation of the lymphocytes that we would like to generate in order to enhance an immune response. And when we look at the PKs of this drug, and when we look at the lymphocytes, we do see that increase in lymphocytes in the circulation and in patients' tumors, translating to that pharmacodynamic effect that we hope to achieve with this improved pharmacokinetics.
So that's obviously takes me to the next question, Arlene. That's just a wonderful summary. And that is, how does the toxicity profile of the pegylated molecule change how the patient receives it, how we deliver it, and what the expected therapeutic index will be?
So once it is given in the circulation, slowly those pegulations are removed, which is resulting in its clinical activity. Rather than getting that profound surge in cytokines that we saw in the era of high dose IL-2, we see this more prolonged but sustained effect stimulating IL-2 via the circulation. So when you think of cytokines, those are very short acting, often very localized. Now we can give a systemic cytokine in a more safe fashion, resulting in less profound hypotension. Although hypotension is still an issue, but usually if that happens, it happens within the first 3 days of the infusion and is frequently managed by increased oral hydration. And we rarely have, actually, I haven't had to admit anyone to the hospital for the hypotension. So now we have a therapy that can be administered as an outpatient and doesn't cause those profound toxicity due to the very high dose cytokines that have effects up front. We see that prolonged modulation.
So that's a profound difference to the more traditional IL-2. I mean, just the idea that this is an outpatient delivered therapy, doesn't require hospitalization and intensive care unit support is a major difference than the historic interleukin-2 that we've given. So Dr. Tenier, let's turn our attention to you. Clearly, when one thinks about interleukin-2 in 2022, what comes to mind is these durable remissions. And one of the markers of activity of BEMPEG is going to be, does it have the same ability to produce these deep, important clinical remissions for patients with kidney cancer that can really affect their clinical activity when administered alone, or as we talk about in a few minutes, when delivered in combination. So what are the responses that you have seen and have been reported with this molecule?
Well, thank you, Bob, for the question. First, I'd like to congratulate Arlene on her excellent summary of the MOA of BEMPEG. But I'd like to add also that I think we can think of the differential between BEMPEG and the native high-dose IL-2 that you and your colleagues pioneered several decades ago, is that BEMPEG is a preferential signaler through the beta gamma subunits or dimeric beta gamma of the IL-2 receptor rather than the alpha, and rather than signaling through the trimeric alpha and beta gamma. So it is that CD122 agonism that really differentiates it from high-dose IL-2. Back to your question about the landscape, as you well know, in RCC and in melanoma and urothelial and others, has expanded with the advent of the immune checkpoint inhibitors. So what can BEMPEG add to this competitive landscape is that we hope that similar to the immune checkpoint inhibitors, we will have sustained responses. And if you look at now the Pivot-02 data, which is phase 1 and phase 2 data in solid tumors that Arlene and I participated in, and our colleague at MD Anderson in the melanoma department, Dr. Adi Diab, also participated in the melanoma department. When you look at that data, what you see is, as Arlene mentioned, every cycle you give of BEMPEG, you see that lymphocytosis in the peripheral blood, and you see a sawtooth appearance with each cycle. You see a sustained lymphocytosis. But again, more importantly, or as importantly, is you see also recruitment increase in the T cell infiltration in tumors. And as you well know, this is important if we're going to have a sustained response of solid tumors to immune checkpoint inhibitors. Those tumors have to be inflamed. We have to recruit T cells. And so what does BEMPEG do? BEMPEG does increase the infiltration of lymphocytes into the tumors. It increases their proliferation and activation with increase in the PD-1 expression on the T lymphocytes. And obviously we know that the target of the immune checkpoint, particularly an anti-PD-1 antibody. The target is the PD-1. And what BEMPEG does in combination with an agent such as Nivolumab is it increases not only the infiltration and proliferation and activation of T cells, but it increases the PD-1 expression on these T cells. And so we hope that with this dual mechanism of, on one hand, you have the PD-1 antibody or the immune checkpoint inhibitors, which acts as a releasing the brakes on the immune cells to go against the cancer cells. And, the BEMPEG is the one that puts the gas on the pedal. So we hope that this is the ideal combination. So just to give you an example of the efficacy of this combination of BEMPEG plus Nivolumab in solid tumors, I would like to cite a recently published manuscript from led by our group here, Dr. Adi Diab, on the melanoma cohort, where it was published in JCO, and it was one of the most downloaded, actually, manuscript of 2021, where in 38 patients with metastatic melanoma, first-line therapy, and 38 patients with BEMPEG plus Nivolumab produced an impressive 34% CR rate and 53% overall response rate, with a median progression-free survival in these patients of 30.9 months, compared to what historically a single-agent PD-1 antibody produced in melanoma. CR rate is 14%, and the median PFS is around 6-7 months. Even with Nivo-Ipi, the median PFS is around 11 months. So this is data that's published that I can share with you and your audience about the effect of BEMPEG plus Nivolumab in melanoma. In bladder, Arlene can speak about the cohort or the trial that she led within that PIVOT-02 trial in urothelial carcinoma. She presented some of this data, I believe, 2 years ago at ASCO GU. I can speak to the about the RCC cohort in maybe a future webinar or an interview, a roundtable discussion like this one, once we have our 2 manuscripts published. Right now, I think the data is confidential about the RCC cohort from that PIVOT-02 trial.
So Arlene, let's turn to you. Let's expand on the phase 1 experience. Tell us a little bit about what your experience is, both in the GU space as well as the toxicity profile of the combination, and obviously share with us only things that are not privileged. But clearly the JCO article excited everyone into thinking about a combination trial. And everybody knows in oncology these days, one of the things that we try and do is turn cold tumors hot, and whether BEMPEG actually can start to incite, with activation of PD-1 inside the tumor, recruitment of lymphocytes, and then adding a checkpoint inhibitor makes that activity greater. So what was your experience with the phase 1? And also share your experience with urothelial tumors.
Yeah. So in our experience in the phase 1 and including urothelial tumors, we saw exactly what you mentioned, Robert. We see these cold tumors, PD-L1 low tumors, and CD8 low tumors. So these are the tumors that traditionally haven't responded to immunotherapy in the setting of urothelial carcinoma. And we saw that with treatment with BEMPEG and Nivo, that we were able to convert these tumors to a PD-L1 positive phenotype with higher CD8 positive T cells. So again, the lymphocytes that we are hoping to generate to induce the immune response. As Nazar mentioned, we see such lymphocyte proliferation that this has actually contributed to pseudoprogressions. I have had patients where the tumors have tripled to even quadrupled in size. And at their first restaging, you'd think this patient certainly must be progressing. But then when you meet with the patient, they say, well, I'm surprised by the CT report. I actually feel better. My pain has improved. And I have one such patient whose tumor did quadruple in size. It was a mass near the pelvic sidewall. And with continuation of treatment, we saw reduction in that mass over time, where we saw that mass have probably at least an 80% reduction or greater for the long term. So again, that pharmacodynamic effect where we're stimulating lymphocytes, we are getting them to go to the tumors where they need to be. We're converting the tumor microenvironment from that PD-L1 low to PD-8 or PD-L1 high. We're seeing it go from CD8 T cell low to CD8 T cell high. So again, all the features that we hope to invoke for an immune response. And when we look at the early clinical data in the setting of bladder cancer, we saw in patients who received treatment, we saw a response rate over 40% objective response rate. And this was despite this being very early data without as much follow-up. So a nice early response rate. We also saw evidence that some of these responses are appearing to be potentially durable, like we're seeing in the melanoma group, where they have 80% of patients who responded haven't yet progressed. And that's at a median melanoma follow-up of 29 months. So the hope is that these treatments will work in that PD-L1 low group, that CD8 T cell low group where we've seen a lack of efficacy with immunotherapy. We've also seen activity in patients with visceral metastases, which is very important in urothelial cancer, where the response rates with liver metastases and visceral mets appear lower compared to the node-only group of patients. And yet, with BEMPEG, aldesleukin, and Nivolumab given together, we're seeing similar response rates in both visceral and non-visceral metastases. So our hope is this will overcome the limitation of immunologically cold tumors. It may help drive responses, especially combined with other features associated with a cold tumor microenvironment, and even enhance the activity of TKIs that may be used in a colder immune tumor environment.
So Arlene, let's extend your experience and let's talk about what practicing physicians are always going to be worried about, and that's immune-related adverse events. So, I mean, we know we have the history of interleukin-2, we have the history of IOs, and now we combine them. And are we seeing some of the endocrine abnormalities associated with immune-related treatments, or are you seeing anything unusual, or it's pretty much the expected toxicities associated with checkpoint inhibitors?
At this time, it does appear to be the expected and anticipated toxicity profile that we're observing with single-agent immunotherapy and combination immunotherapy strategies. I do have a sense that the hypothyroidism does tend to come on a little faster in patients receiving this combination, which could be a result of, we're just fueling the fire, driving a better and faster immune response. So patients do head toward that hypothyroid state a little quicker. We've seen a little more, perhaps a little more hypoadrenal or low cortisol levels, hypoadrenal state. But again, you can give replacement therapy for that. So at the moment, it appears very similar to what's been observed with immune checkpoint inhibitors with a similar profile. The biggest difference is we do see some of those IL-2 effects, but it's not as profound. We see hypotension that's controlled with fluids, fever and myalgias, usually controlled with Tylenol. And most patients report these types of symptoms lasting a few days, up to a week at most. And then as they continue on treatment, the effects do seem to be a bit abrogated, so they do tend to improve over time.
And obviously, when we think about combinations like Ipi-Nivo, where it's both checkpoint and CTLA-4 blockade, there's a high frequency of the need of steroids. Has steroid use been frequent or infrequent in the patients receiving the combination of BEMPEG and Nivo?
I would say it's similar, at least based on my experience. It really depends on that frequency of the immune-mediated events that require steroids, the pneumonitis, colitis, and myositis. So like anything that stimulates the immune response, these toxicities can occur, and in my experience, it has been a fairly similar use of steroids across both the BEMPEG, aldesleukin, Nivo cohort and patients who we've treated on single agent immunotherapy. There's even been some debate, even with Nivo-Ipi in bladder, we haven't seen a substantial increase in toxicity. And, how much of that is based on experience? We've gotten better at recognizing these toxicities earlier and treating them more effectively earlier. But overall, I would say it's similar to what we've encountered already with other immune checkpoint inhibitors.
That's great. So Nizar, let's turn our attention to the Pivot-09 study, which is really the randomized trial. So you're an expert in kidney cancer. You've been doing this work for years now. And that trial is basically going to be a combination trial compared to a TKI. So help us understand, what your thoughts are around the design of the trial, the readouts of the primary and secondary endpoints, and what you're hoping to obtain with this prospective phase 3 trial.
Yeah, thank you, Bob, for the question. I mean, when we designed this trial, now this is 2018, 4 years ago. Obviously, we were aware of the landscape had quickly changed with the approval of several of the immune checkpoint inhibitors regimens. And so obviously Nivolumab, Ipilimumab was approved for patients with intermediate risk, poor risk. And then, following that, the 3 IO TKI regimens, as you're well aware of. So we really struggled with the design. Would we choose for a comparator, as you mentioned, a single agent TKI? So in many, obviously, when, we were thinking of designing this trial and making a registrational trial, a phase 3 trial, we wanted to make this an international, a global trial. And many of the countries outside the US and maybe some of the European countries, these regimens, Nivo-Ipi and the IO-TKIs, Pembro-Axi and Nivo-Cabo and the others were not approved. And in some countries, actually, they're still not approved. So we really wanted to make this a global trial, and a single agent TKI was approved in many of the countries that participated. So we chose sunitinib. We made it a investigator or dealer's choice, as they say, between a sunitinib or a cabozantinib. In some of the countries, cabozantinib, like in the US, was an approved age TKI as single agent. And so so obviously the phase 3 was basically a randomized 2-arm study of the combination of BEMPEG plus Nivo versus sunitinib, where sunitinib is approved in the countries where it's approved as first line, and in countries where cabozantinib is approved, cabozantinib. And the 2 co-primary endpoints we selected for this were objective response rate and OS. The good news is the trial did reach, despite the pandemic, the global pandemic, we were able to enroll upward of 600 patients on this international trial. And we, recruited the last patient over a year ago. So we hope that this trial will read out this year. We hope that the combination will show the activity and the promising results that we saw from the single-arm study of Pivot-02 with BEMPEG Nivolumab. So I think just wanted to add why is, in my opinion, and for an investigator such as yourself, who built a career about high-dose IL-2, why would this BEMPEG-NIVO be, a promising, exciting, maybe an alternative in some risk groups, for example, of RCC. Again, it's because the toxicity profile is so favorable. And I'd like to really expand on what Arlene mentioned. You brought up the corticosteroids. If you look at the Checkmate 214 study, the percentage of patients who required high dose corticosteroids was 35%. So, and the discontinuation rate because of immune-mediated adverse events was 22%. So, in our experience from leading several of these pivot trials, we see that the discontinuation rate because of AEs is very low. And I would like to contrast my experience in RCC. That's what I see. And Arlene obviously spoke about her experience in patients with bladder cancer. In my experience with RCC, the actual utilization of high-dose corticosteroids with the combination of BEMPEG Nivolumab was really low, and we saw really low discontinuation rate because of IMAEs. So in my experience, in my opinion, I think the BEMPEG Nivolumab does bring an advantage over the other IO-based regimens in that there is less discontinuation rate, there is less utilization of corticosteroids, and we have not seen an increase in IMAEs, at least in the RCC patient population, over a single agent anti-PD-1. And certainly we see that there is definite decrease, lower rates of discontinuation and IMAEs compared to Nivo-Ipi. So if we can achieve with BEMPEG-NIVO the same efficacy that we achieve with say, the IO-based regimens with IO-TKI or Nivo-Ipi, but with lower rates of discontinuation and adverse events, I think we would really have brought to the clinic and to patients a really promising, effective therapy that we all look forward to really prescribe to our patients.
So Arlene, I want to circle back to your comments about the phase 1 trial. And the reason I want to do that is because I'm intrigued by the conversation that we're having about turning cold tumors hot. And clearly one of the ways that we would demonstrate that would be in the second or third line setting where a person has received prior IO therapy and then gets the combination, and now all of a sudden they benefit. Was there anyone in the phase 1 trial that had received prior immune therapy that then benefited from the combination with BEMPEG?
So unfortunately, that was not studied as part of our PIVOT-02 and in GU tumors. So though you raise a great question, could it take some tumors where a patient hadn't responded to immunotherapy and enhance the immune response? Could there be scenarios, say in a post-chemo treated patient or a post-TKI treated patient, where the use of this combination could have clinical activity? I would have to say the potential is there, although it hasn't yet been explored since the decision was made to try it in the upfront setting, since we saw such good early clinical activity in this group of tumors. And for the bladder cohort, given the single agent use of immunotherapy in the PD-L1 high group of tumors, but the lack of utility in PD-L1 low, the phase 2 trial in urothelial cancer focused on that frontline PD-L1 low group of tumors to see if this could provide a potential benefit compared to what had been observed historically with single agent immunotherapy. So again, trying to provide an option for patients who might not be good candidates for systemic chemotherapy. But could it enhance an immune response as post-TKI in combination with a TKI? I think it's very likely that it could. And I hope that some of these trials do turn positive and there's incentive to continue studying this combination further.
So guys, let's bring this to a close by asking each of you to kind of summarize your experience. These are, I'll turn to you first. Summarize your experience and then summarize for us, for the people that'll be listening and reading, what they should be looking for over the next 1 to 3 years as the readouts start to come from the pivotal trials. Because clearly, one of the challenges for these combinations is when oncologists hear the word interleukin-2, they sometimes get startled and wonder whether that's something that they can do. And it's important that they start to understand that BEMPEG, as Arlene nicely pointed out, is not 1990s interleukin-2. It's a 2022 molecule with pegulation and a different therapeutic index. So how would you summarize where the field is today and where it's going, Nizar? And then I'll ask Arlene the same question.
Yeah, thank you, Bob. So BEMPEG is a novel agent, and clearly I'll summarize the advantages. As I mentioned, it signals preferentially through the beta gamma dimeric subunits of the interleukin receptor. So it has a 20-hour half-life rather than 20-minute half-life compared to the high-dose IL-2. It can be given as an outpatient. We have not seen, when we gave it monotherapy and when we gave it in combination with an anti-PD-1 like Nivolumab, we have not seen an increase in the immune-mediated adverse events. And we've seen, because we've done in the Pivot-02, the phase 1, during escalation and later expansion in the different solid tumors, we've seen when we did biopsies baseline prior to therapy and biopsies 3 weeks later, and when we collected blood on these patients weekly after the infusion, monotherapy and in combination, we've seen lymphocytosis, as we spoke about. In the tumor microenvironment, when we did the biopsies, we saw in expansion, an increase of infiltration of T cells. And we saw increase in the PD-1 expression on T cells. And as Arlene mentioned, in some tumors, in fact, in bladder, patients with bladder cancer, there was 70% conversion of PD-L1 negative to PD-L1 positive tumors. So in aggregate, all these different effects of BEMPEG are salutary and are, I believe, a step forward to really hope to break the cure barrier. Now, what can I see? What do I see in the next, obviously, year to 3 years? There are 3 registrational trials. One in melanoma in first line, BEMPEG plus Nivo versus Nivo. Again, the trial complete accrual. We hope to have the readout this year. The Pivot-09, as you alluded to, Bob, of BEMPEG Nivo versus the TKI of choice, sunitinib or cabozantinib, we'll have the readout this year. And then the third, Arlene, is the global PI of that trial, Pivot-10, looking at the cisplatin ineligible and low PD-L1 in bladder in more than 100 patients. So we'll see. We hope that all 3 of these trials will be positive and will be able to bring this combination to patients with melanoma, with RCC and bladder. And where we are going forward is obviously not just because, as you well know, Bob, the field is moving to triplets and quadruplets. So we hope, and we have done already started looking at triplets of BEMPEG Nivo plus a TKI. So there's a trial, Pivot-011, again, partnership of BMS and Nectar Therapeutics and many investigators at academic institutions, where we are looking to see the triplet, the efficacy and safety of the triplet. And I can share with you that preliminary data, at least in my experience at MD Anderson, having treated some of these patients with the triplets, that it's deliverable, it's safe. So we are able to give a TKI that's FDA approved for RCC, like cabozantinib, plus Nivolumab, plus BEMPEG. Obviously, we'll have to finish the trial, and it will be a randomized trial looking at the triplet versus doublet. So I think it's exciting time for the field of solid tumors, where in the past, during your tenure at UCLA, Bob, when you led many of these high-dose IL-2 trials, from application or use or utilization in just 2 tumors, melanoma and RCC, now we see the expansion with BEMPEG how in combination with immune checkpoint inhibitors, plus or minus TKIs, or chemotherapy, or other cytokines, where we are now seeing, hopefully, application in many solid tumors. So we're expanding the indications of, this novel CD122 agonist to other solid tumors, and not just melanoma RCC.
So Arlene, in your hands, great experience, in-depth understanding of the biology. Where do you hope this combination therapy is going, especially in urothelial tumors? I mean, we have had such challenges with urothelial tumors for decades, and we've always basically been, platinum people, trying to find ways to take care of people that we didn't feel like we were doing the best that we could. And now all of a sudden we have immunotherapy, and now we have BEMPEG, which could add to that. So what are your hopes for the next several years for these patients with urothelial tumors, especially in your experience?
So what I am hoping for is the ability to apply that durability that was seen very early in the high-dose IL-2 era, and now apply it to groups of patients who were never candidates or never would have been candidates for an IL-2 directed therapy. The improved toxicity profile is real. Back when I was a resident, we gave the high-dose IL-2, and after the infusion, we handed the nurse the patient's transfer orders for the ICU in case they would need that rapid transfer. But now we're able to give this IL-2, this new way of giving it, BEMPEG aldesleukin, 6 pegulations on it. We're able to give it as an outpatient. We're able to do it safely, even in elderly, frail bladder cancer patients. I've treated several patients with Parkinson's disease, and I think anyone who's given chemotherapy to this patient population will tell you chemotherapy is bad on nerves. It worsens dementia, it worsens Parkinson's. So I think we are developing treatments that can be applied more widely into elderly, frail bladder cancer patients, given as an outpatient, and hopefully result in that durability of response that led us to continue high-dose IL-2 20 years ago because of that potential for benefit.
Yeah, so let me just say, Arlene and Nizar, it's a wonderful opportunity to chat with you. I know that you're in Houston and I'm in Los Angeles, and just hearing you talk about a next generation of a molecule that we know had profound effects, but in a very few patients, offering patients the opportunity to go from cold tumors to hot tumors, outpatient-based therapy, no additional immune adverse events to what we would have otherwise expected with our current checkpoint inhibitors. It continues to be an exciting time. And I agree with you, Nizar. I mean, while it's in melanoma, kidney, and bladder cancer today, there's no reason to think that the portfolio of this combination couldn't be expanded to other immunologically responsive or non-responsive tumors. So that was great, guys. That's exactly what we wanted. You guys are spectacular as always. Thank you both for your time today. Please be safe.
Thank you, Bob. Thank you. It's a pleasure to be with you, Arlene. And Bob, thank you again. You're absolutely the best moderator I know of. And it's a pleasure to be with you.
Nizar makes it very easy. Thank you so much.